So confusing needs and wants, and this is by far, in my opinion, the second most after the shoulds. The needs and wants is simply what you need is what you need for survival, like air, like water, like food, and anything in life you want it and you are not in need of. So you want a mobile phone, but you will not die because of the absence of the mobile phone. So you have to understand what do you need and what do you want. Because if I think of things as being needs and not only wants, this means that I will treat things that I'm missing exactly the way that I will react to um, not being able to breathe, for instance. Just because I don't have water, I don't have air, or I don't have something important for my survival. And this is very important because we also teach the patient to try to describe situations the way they are and not utilizing their metaphors and that stuff. Because you know how the brain is working. You know that we have the left side of the brain with the perisylvian area that's responsible for giving meaning for the language we say. And then the right side of the brain will automatically construct an image that corresponds with what you say. And that's why if I'm asking you just right now to close your eyes, all of you, just close your eyes, all of you, and try not to imagine an elephant that walks. What will come to your mind automatically? An elephant that walks. And why you did not take in consideration that I asked you not to imagine an elephant that walks? Because the only hearing the sound elephant will directly construct the image of an elephant by the right side. And this is a reflex. I cannot erase it. It's out of my control. And that's why if you are telling, for instance, that he blowed me up, he crashed on my face, and using a lot of expression. You know what those expression is really doing? This is the image you are putting in your mind. And this is how the image is really constructed in your mind. So instead of saying that he crashed on my mind, I don't know how to say many of the expressions, but every language has its own expression to express being enraged or being in anger in a certain way. But those images with metaphors are in fact constructed as being a true image. And this doesn't do a positive effect. It increases your anger. Confusing choice and force. Sometimes patient coming to you say, well, you know, I'm not coming for you because I do like therapy. I came to you just because my parents brought me here, and I'm obliged to do so. And I think this is a quite common answer. And such force, we teach the patient that the only way you are forced when you are brought and you are captured, and then you are coming against your will. But what you did do right now is simply to choose between two bad things, either to come to therapy or you will find that your parents are angry against you most of time. So you choose to come to therapy. So this is not being forced to get to therapy, but you have chosen between two bad things that you don't like, which is a normal situation that you have to do in life. Can't stand it is extension of the needs and want. Catastrophizing, the magical worry, thinking that I have to be worried so that I can keep my eyes on children. I have to be worried so that I can do fine in my exams and so on. The irrational definitions, like for instance describing someone as being I'm too short, I'm too long, I'm too dumb, and what this too short stands for. I mean, if you are short and you want to be a basketball player, maybe this will interfere with your goals, but what does being short to interfere with you if you want to be a good doctor, for instance? Confusing relying and depending. I cannot live without one person. Of course you can live. You are relying on him on a certain things, but you are not dependent on him. Confusing inability and willingness. Are you truly unable to do something, or you lack the true will to do something? Confusing possibility and probability. We use that particularly with patients with obsessive symptoms. So there is a possibility that you will have infection, but what is the probability to have it? There is a possibility to have a car accident, but what is the probability to have it, and so on. The projection and the upset about the idea rather than the fact. I mean, if someone is really upset and very upset today because there's something happened when he was coming to the appointment, you will ask him, I know you're feeling and I can understand your feeling, but what does this situation really has to do with your goals for this day? If this distressing event is really not blocking your goals, I can understand how empathic with people should be, but this should not intervene with your ability to continue your day, because always I have to ask myself, do I distressed from the situation because I'm distressed from the situations, or am I distressed from the situations because the situation is really blocking the way to my goals? Nonsense argument, like arguments from the past, hopelessness and helplessness, too much, too little, the ambivalent beliefs. This kind of belief is the kind of belief that has no definite answer in CBT except for dichotomic answer as well. Ambivalent is like, for instance, a husband coming and he's cheating his wife, and then it is that I cannot stopping that because I do need some sort of contentment from the other woman, and I feel some sort of guilt. So here we have ambivalent ideas that have only one answer, which is dichotomic. So either you quit your belief system and you feel that you are not guilty anymore and go into your behavior, or you have to learn more behavioral strategies to stop your behavior and get back to your believing system. Correlation equals causation. Not because two situations are correlated, this means that they are cause and effect, and the global thinking is simply to think in a global way rather than multidimensional one. So the situation is getting bad, the situation is getting catastrophic. What is the situation? What do you mean by situation? And what are the different components of the situation? What exactly in the situation that goes bad? When you say, well, the economy is catastrophic, what's in the economy is going catastrophic, and so on. So trying to replace this global way to see things into a multidimensional, multi-component system. So what really happens when you go through the CBT and you start by the situation, the behavioral, and then challenging those alternative ideas, you will find that most of patients are using maybe 2 or 3 predominant negative ideas. So you are starting some exercises with them to replace it with alternative ideas. You start by encouraging them to think themselves and to find an alternative. When they don't find, you go more didactic and you teach them what alternative you have. What happens is that as far as you go more didactic, more resistance will come, simply because patients do not like that you dictate what they should think or what they should behave. And this is reality in human being. So I will get back to the change model of the Prochaska and Declamant that is used for the abuse. And what happens is that in many patients doing psychotherapy, you will find them not all the time going in the proper direction. Sometimes they are going in the opposite direction, as the red arrow shows. So they took the decision and then they have the action. But sometimes in the middle of the therapy, they are revising back again whether the decision to go through psychotherapy was right or wrong. Or sometimes they're getting the contemplation, I think that you are trying to change me, I don't want to change, I'm a good person. So sometimes people are getting back again in the opposite direction. And for those patients having resistance over time, so you may suggest some alternative ideas, and you ask the patient to repeat those alternative ideas through what we call action planner, and most of CBT modalities have a sort of action planners. As far as they repeat the imagination of the situation with the proper idea, they may change it over time. But patients do show resistance to CBT. And by the way, though the CBT is the psychotherapy with the most evidence-based data, but a very interesting article published by Professor in Edinburgh, I don't remember the name. He made the largest meta-analysis of the psychotherapy trials where the CBT was compared to a non-specific psychological intervention, and he found that there was no difference. So the fact that the CBT in most of cases is CBT plus pharmacotherapy against pharmacotherapy alone. And this is how a more efficacy of the CBT is being brought to evidence. But if you compare those trials which compared a CBT to a non-specific psychological intervention, results are the same. And this raises a lot of questions. What really improves the patient in psychotherapy? Is it the CBT technique? Is it the feeling that the patient is well taken care for? Is it the direct effect of the therapist? Is it the attitude of the therapist in a CBT? Many components of the psychotherapy process really need to be addressed and issued in further research. So the integrative psychotherapy is one of the solutions for that. You know that when people started using the psychoanalysis, which was the main psychotherapy maybe 70 or 80 years ago, and there was no other psychotherapeutic modalities, well structures like the analytic therapy, and all psychotherapies were using the same tool. It was more or less quite calm. And then when other psychotherapeutic modalities came to the surface, then people studied more and more of the different psychotherapeutic approaches. And then some of the therapists were using techniques from here and there just to find positive results with the patient. This is what we call eclectic therapists. And the eclectic therapists do not care what really improves the patient. They only care if they do use one technique and it doesn't work, then use another technique. If it doesn't work, use the third technique, and that's it. Without that scientific foundation. Does it really work? Maybe it works on many things. And for the integrative model, because most of psychotherapy, it seems that in literature, most of data coming from literature are telling that around 40% of psychotherapists are not adherent to the protocol. So when you are using CBT, you are not adherent to the protocol. Just being adherent to the protocol or to the principle exists in research community, but in real life, the patient is getting resistant by that way, so I have to manipulate somehow. So how are we going to manipulate? And this is the proper question. So we have different models for the integrative psychotherapy because of the psychotherapy integrative models is not only concerned by deblocking the resistance, but it also is interested in to study what elements in the integrative model really worked better with the patient. And that's why we have a common factor model, a common factor to see what is in common between the different psychotherapeutic approaches, so that this common factor may be the one that really improve the patient. And one of the most well-known argument for such a model to study the common factor integrative model is the bottom-up model for the psychotherapy. You know that if you are going to give medications to a patient, you are going to change the chemistry in certain circuits subcortically. And when you change the chemistry at the subcortical circuitries, you will change the way you think at the level of the cortex. So it seems that the pharmacotherapy simply works bottom up, so from down to upward, from the subcortical structures to improve the way the cortex is working. While when you work with psychotherapy, regardless of the modality, you are tackling the way the cortex is working. So it changes the chemistry of the subcortical structures. So it is top down. So what really happens is that top down, bottom up, but at the end the same changes will take place. And this is what has been brought to evidence by the functional imaging of people after psychotherapy. Technical eclecticism. This means that I'm using techniques, and those techniques are not in conformity with the principles of the current therapeutic approach I'm adopting with the patient. But if as far as it works, it works. For instance, supposing that you go with obsessive compulsive and you do an hierarchy and then gradual exposure, and you find that it doesn't work, so you go paradoxal and complicate more and more the obsession symptoms for the patients. This is based on a completely different concept coming from the systemic approach, telling that you don't have to ask why the symptom occurred, you have to ask what does the symptom serve to the patient. And so you have to complicate the symptom more and more so that the benefit from the symptom will be outweighed by the badness of the symptom. This strategy is completely different from CBT, for instance. This is an example of technical eclecticism. So you are using just different techniques, regardless whether they are in conformity with each other. And it seems that the eclecticism is really working fine. And you have the assimilative integration, where you are maintaining a certain psychotherapeutic frame, but you are just integrating only one strategy inside the mainstream of the psychotherapy. But this strategy comes from a different modality. And this assimilative integrative model I do prefer. And we have a theoretical integration where different theories can be brought together to widen the area. For instance, one of the best examples of theoretical integration by excellence is the integration between the existentialistic therapy and the CBT. And sometimes you cannot get them separated on a practical basis, even if you are not aware of what you are doing exactly. But questioning the meaning of life and the role of life and all that stuff, although it's part of the existentialism as a philosophy of life, but it's integrated as a theoretical integration with the CBT model. And the three-stage model has been proposed by some authors, and they do propose a three-stage. The first stage is called the exploration, which is inspired by the person-centered psychotherapy of Carl Roger, and then the insight phase, which is the second phase, which is based on the psychoanalysis, and the third phase, which is the intervention based, is based on CBT. This is called the three-stage model. There's a very interesting conference for those who are interested in the integrative psychotherapy. It's called the Society for Exploration of Psychotherapy Integration, and they are conducting their annual conference next month, in 16th of June, at the Trinity College in Dublin. I'll be conducting another workshop based on a practical approach to suicidal patients, with my suggestion as an assimilative integrative model to tackle the morality system. Why do I take the right decision that I have to die is a right decision after all? So we come to the hypnotic techniques, and the hypnotic techniques is based on the hypnotic state, or what we call the trance. And the trance is simply an altered alertness stage. Whenever you are driving your car, sometimes you are driving your car back to your home, and you are not fully aware of those directions, but you are just driving as if you are doing an automatic. This is a trance. And the trance is, as Professor Jager said this morning in his lecture on pain, that the hypnotic phenomena is occurring every day, even if you are not aware of. So the hypnosis was done by direct suggestions. Started with Mesmer, who was stopped from his practice because they were believing he is using demons and so on. And then till reaching the indirect way of hypnosis. And was very revolutionary because it has been proposed by Milton Erickson, and then they spread it over time. And the indirect hypnotic suggestions for me are much more appealing. Though I studied hypnosis for a long time with the French Institute of Hypnosis, I don't know why I don't feel very satisfied with that. And whenever you feel unsatisfied with something, don't do it. This is my opinion. But I enjoyed a lot the hypnotic communication and not the hypnosis as a practice, because you know that data coming from literature say that the data you come or the results you get from hypnosis are not maintained over time. But the hypnotic communications is not only therapeutic tools by their own, but you can manipulate the way the patient is really thinking in front of you. And this is a very interesting, and I will propose some of them. This is our interesting books, and this book is very interesting. It's A.RADY. I think this is the French version for those who are interested in. This book is very, very, very beautiful in terms of the hypnotic communication. It's called the Therapist Out of Common, or Therapist Extraordinary Therapist. I don't remember the exact title, but this is the French translation. So here are the main target of my workshop is really to use those different techniques. And those techniques are used by marketing specialists so often to convince you to buy something. Let's go for the truism. The truism is simply to ask the patient a consecutive several questions where the answer is only yes, so that you put the patient in the yes mood. So whenever the patient say, I can't, for instance, how can we tackle that if the patient is insisting that he cannot proceed further or he cannot continue furtherly? So you ask him, do you like your children? Do you think that you deserve a better life? Do you think your situation should be better like that? Do you think that you merit a better thing? So all the question is yes. What are you saying? You are putting him into the mode of yes, and then asking him back again to get into therapy. You see, these things are really used by the marketing specialists when they are trying to market a real estate or something. For instance, a chalet on the plage or something like that. You will say, how much you spend? Do you think that you deserve to spend more? Do you think that you have to pass 2 or 3 weeks in family? So all that questions, the only answer is yes. It's simply you put the patient in the mode of saying yes. So whenever he is blocking and saying that no, I cannot continue like that, I cannot do that. Why? You have to ask why you are telling that. Do you think you don't deserve a better life? Don't you like your children? Don't you want to carry out your responsibility as a good father? So all those questions are simply yes. You are putting the patient on the mode of yes. It's very interesting. The implication suggestion. You know that whenever you get to a car selling agency, and then you are trying to see the car, you will find that the salesman will get you the key and will say you, well, try to try yourself, just try to use it, just try to sit inside the car and see how it goes. It simply let you to feel or to act as you own it. This implication is exactly the same. Implication questions. For instance, the patient come with you and say to you, I have been depressed for 30 years now, and I have been going to many psychiatrists before, but I think nothing is really working. And you simply ask the patient, what are you going to do first when you think that your depression has gone away? I don't care what the answer is. You just want the patient to feel as if the depression gone away, and just to try to speak about what happens after. This question is what we call the implication question, and it is part of the indirect hypnotic techniques. So you ask the patient a question, not to search for the proper answer, but simply to let the patient feel the way that He has already been cured. What are you going to do when your panic gone away? What are you going to do when what are you going to do first when you are very confident of yourself, in your opinion? And these things, just to let you imagine that you have quitted your pathology. This is what we call the implication question, exactly the same way as when I give you the car and encourage you to make a test drive, for instance, just to get into the car and try to use it your own. The time bind as indirect hypnotic suggestion. The time bind is people do like to have the impression that they are free to have choices, and what's going with the time bind is simply you make several choices, but the bottom of the line is that you are going to improve after all. So you may suggest that some patients do improve after 2 weeks. Some may need 3 or 4 weeks, and some may even need up to 6. So what you are suggesting is that you are going to improve after all, but there are different people that will improve with their own rhythm. So these are called the time bind. Time bind because I'm binding the choices. I'm closing between different choices, so you have the impression that you have different choices. But the bottom line is that you are going to improve, whether after 1 week, 2 weeks, or after 4 weeks. Non-sequitur double bind means that you are giving two suggestions, but in fact both suggestions are the same thing. Like for instance, when you tell someone you have to get your relation better with your wife, or stop arguing all the time. In fact, it is the same thing. You have to respect your appointment, or try to keep always try to be adherent to the schedule. I mean, both suggestions are in fact the same thing, but rephrased. The conscious-unconscious double bind means that you give the impression that you are going to improve over time, whether you are aware of the mechanism of improvement or not. Like for instance, you can start a therapeutic process to get rid of these depressive manifestations, or you have to wait that those depressive manifestations disappears over time. This is called conscious-unconscious double bind, because you are suggesting that those depressive manifestations will disappear anyhow. The apposition of opposites bind. It's turning the negative point into a positive. Like a patient coming to you telling you that I have been very depressive for 20 years, and I've tried several medications, and I went to several psychotherapy. I don't know whether that really psychotherapy will work for me or not. And what we are putting here is just telling the opposite. In my experience, the more you are depressed, the more you will enjoy your improvement after getting into therapy and getting things back on the track, back again. And this is what we call the apposition of opposites, because you turn the impression that the patient gets that he has a longer period of depression, meaning that he will be resistant into positive things, because the more he is depressed, the more that he will enjoy his improvement after. The illusion of choice bind is like giving the different, for instance, when will you come for the next appointment? Is it next Tuesday or the Tuesday next week? So you are just giving some choices, but in fact you are binding the patient. You are binding the patient into a certain thing. The embedded commands is a hidden command which the patient hears inside a sentence. Like for instance, a patient doesn't like to go to therapy, and then you will tell him a story that there was the week before you were with another patient and he was exactly doing the same, and all of a sudden his wife shouted at him, "You have to go to therapy," and then things went fine. You have to go to therapy, you have to raise your voice a little bit, and so that if you are giving a command direct to the patient, because in fact what happens is exactly as an academic person, I feel it in the oral exams, for instance. Students are coming saying the examiner told me that and told me that, and they do remember a lot of details, while the examiner doesn't remember all that details. Because what's important is that the patient is getting a lot of ideas from the therapist. Sometimes the therapist is not aware of everything that he said. And hope you enjoyed things. Thank you very much for that. I think we are just terminating in our time. Do you have questions? Well, thank you very much for keeping you very late. Yeah.
Thank you very much. Very interesting presentation. I would like to say something about the cognitive mistakes you mentioned before. Thank you. I think some of these cognitive mistakes are grounded very early in our life, in the early years. For example, the personalization and blame, or the should statements, I think come from the parents, and then they are embodied to the child and become part of the child's personality as he or she grows up. I don't know, you want to comment on this? And one more thing, you compared the needs and the wants. What about the psychological needs? They are not necessary for survival, but they are necessary for a mentally healthy life. So are they necessary or not, according to your opinion?
Well, for the first question, thank you very much for that. I think many psychotherapeutic approaches tackle the question of shoulds, and one of the first was Karen Horney, who was one of the students of Freud himself, and he said that as far as you are doing well, so you are gratified by the caregivers, and as you get more and more gratified by the caregivers, you will or your real self is getting confused with the ideal self that is imposed by the external environment, and from where the should system comes, because you should do that to be ideal and to be gratified by others. And this is how the should system, according to Karen Horney, is the point of reference is externalized from being my real self to an ideal self that does not go in exact conformity with their real self. So the shoulds has been tackled in many ways. And this is a good example of how theoretical integration should be understood as a concept of integrative psychotherapy. It is the same concept, whether how these shoulds came. So you may consider that the shoulds is a blocking phenomena, and this shoulds is automatic negative thought according to the CBT, is the source of pathology according to certain new Freudian schools. But the way these shoulds came from can be considered a core beliefs in the CBT and so on. So it's different nomenclatures or some sort of theoretical integrative model. For the psychological needs are those needs that should go in conformity so that you can achieve your goals after all. And this is the ultimate goal of the rational therapy is to help you to reach your goals. And we are not to run the patient's life and to tell them what kind of goals they should have, because no one should have anything after all. You have your own goals. I'm trying to help you to achieve those goals. And these goals are, in most of cases, are partly mental and partly physical.
Thank you very much.
Yeah. So thank you very much. For this workshop, I have a continued dedication because it is accredited on 1.5 hour continued education from the American Board of Medical Psychotherapists. So I will distribute the continued education forms. Thank you very much.